My name is Shannon Robshaw. I'm with the TA Network for Children's Behavioral Health. And welcome to the second meeting of the Rural Behavioral Health Collaborative, Learning Collaborative. Myself and Ray Beaudre, whose name is also on the slide here, are our key points of contact for the Learning Collaborative. If anyone wants to reach out with topics, suggestions of topics for future webinars, or to share resources, or even just give us feedback about the webinars you participated in, we would welcome that. Usually we meet every other month with a webinar and sharing of information. Normally we would meet in July, but because it's going to be summer and people are going on vacation, we're going to push it back a month to August. So the next webinar will be the first Friday in August, and then every other month after that. That will be August, October, and December. And the topics that we're likely going to address in the last part of this year will probably be things that we've told you about before and you showed some interest in, including partnerships with faith-based providers, partnerships with primary care practices, and also we may be looking at strategies for engaging with family and youth in rural areas. A link to this webinar will be sent out automatically to you since you've registered for the webinar. And we've also put you on the Rural Behavioral Health Collaborative listserv if you've registered for this webinar. So if you don't want to be on that listserv, just email myself or Ray and let us know, and we'll take you off. And you're certainly free to forward that to others as well if they would like to join the listserv. And so we can share resources and materials through that listserv, as well as, again, you'll be receiving a link to a recording of this webinar when it's done. So we're going to start with some polling questions so we can see who's on the call with us. So if y'all could answer that question. So everyone, there we go. All right, that's interesting. Definitely majority mental health agency folks. A Medicaid person, it's always good to have Medicaid people involved in the conversation, and a private provider of services. So thank you for that. And then we want to kind of understand your role in your organization, if you could answer that question. So everyone's a project, there we go. Executive leadership. Family engagement lead, we're always glad to see family and youth leads participate in all of these webinars. All right, great. So most everybody's involved with the SAMHSA grant, and actually the project director of the grant. So that's interesting. So good to know. Thank you for completing the poll. It's nice to know kind of who we are all around the table together. So we have, I think, a really terrific webinar for you today. I'm very excited about it. We're focusing on network development. That's always an ongoing topic of conversation. And it's especially challenging in rural areas. And so we wanted to think about some sort of alternative strategies to help develop rural networks, provider networks. So we have Oklahoma represented, who will talk about standing up their new mobile response and stabilization system. And then we have Southern Illinois, who has been successful in establishing setting up a process to stand up more evidence-based practices in rural areas, some creative strategies for doing that, and then telehealth strategies from New Mexico. So I think we're going to learn a lot today. So we're going to let Oklahoma open it up. So Shamika Williams is here with us from Oklahoma, and I'll let you take it over, Shamika.
Thank you. Hello from the state of Oklahoma. My name is Shamika Williams. I'm the Senior Director for Oklahoma Systems of Care with the Department of Mental Health and Substance Abuse Services. And so again, just a little bit of background about the state of Oklahoma. Oklahoma has been a SAMHSA grant specifically around systems of care since 1998. We are a statewide system. We currently have 77 counties in the state of Oklahoma, and most of those counties we consider rural and some frontier. We have two main urban areas, which will be Tulsa and Oklahoma City, but most of our counties are pretty much rural. In our state, we have state access to telehealth, as well as the utilization of FaceTime, Jabber, and hospital telehealth as a way of making sure that there's access in the rural parts of our state. Oklahoma is very much a systems of care that highly recommends and highly utilizes the wraparound model, and the wraparound model pretty much is really our base for the services that we provide in our state for kids that are considered SED or kids that have high mental health needs. As I go into the presentation, Oklahoma has really adapted their model from a variety of other states. We've had consultation with the state of Connecticut, New Jersey, and we are also really good friends with Wraparound Milwaukee. And so, again, kind of taking and borrowing from other states in order to develop our state model. And so as I go into the presentation, Oklahoma has decided to go statewide with a mobile response and stabilization system. And in this system, we have some pretty lofty goals. But ultimately, what we want to be able to do is to aid in the crisis as well as the behavior outbursts for kids in our state. We want to make sure that families who do not have access to the resources or supports in order to aid in crisis have a support system that supports them. And so we look at about 7 or 8 main priorities for us is really creating a rapid response system that would actually be able to aid to those immediate threats and those symptoms that are pretty problematic. We want to make sure that we provide assistance to families and youth in order to de-escalate those behaviors, as well as to make sure that we maintain our kids in our state in the least restrictive environments. We want to make sure that our response systems are pretty much community-based. We believe in providing support to families in their communities, in their home, and as much as possible to maintain them in lower levels of care. We also want to effectively engage and assist our families in developing plans that will make sure that we appropriately utilize treatment to aid in some of those risks. And ultimately, as I mentioned before, is to make sure that these young people stay safe as much as possible in the least restrictive environment. And then also identify the community supports or the support network or system, as well as community partners to help our families to be able to maintain. And so, again, as we have developed a system, ultimately it's based on those priority goals for our state. And so my question is, has your state implemented a children's mobile response system? And so the polling questions are about to come up. And so, again, you can answer those questions yes or no, unsure, or you can choose not to vote. Okay? Okay. Okay, so quite a few responses. And if your answer is yes, which of the following services are available within that system? Great. And so it appears that there are some access lines in many other states in order to aid and support children and families. Okay. Thank you for taking that poll. So in the state of Oklahoma, we have contracted with providers throughout the state in all 77 counties. And as a part of those contracts, we provide reimbursement for the actual services that will be provided. We also provide an infrastructure support cost that will actually help to aid those providers into building the infrastructure in order to provide the mobile response. Currently, right now, we're utilizing our Systems of Care expansion grant that we're currently in as a way of providing that financial support to our mobile response providers in the state of Oklahoma. What we also have is we are in the process of really moving forward with the statewide access line, and this access line is a 1-800 number that anybody in the state of Oklahoma can access. So whether you're the parent, whether you're a school system, you can be a child welfare worker, juvenile justice worker, anybody in the community, when in fact you have a young person that is in need of stabilization services, you can call this 1-800 number. The one thing that we like about the concept of the 1-800 number is that it doesn't necessarily matter what county you're in. If I'm in one county, you don't have to remember a single number to the provider to access those services, and in each of our providers may have different numbers to where you can access them, but this statewide access line will give you one number to call no matter where you are. So if your child is visiting the grandparents or family members in another county, that family would also have access. This access line would provide the opportunity to really look at these calls in multiple different ways. We want to make sure that any of our calls that will be coming in, people are routed in the most appropriate direction. And so oftentimes we know there will be calls coming in where families really need access to resources and supports in order to aid them in their situation. So we want our call center to be able to divert those calls to maybe a reach out or a 211 resource line. We also want to make sure that when in fact those calls come in, and if any of those calls are what we consider emergencies or high-risk calls, that our call center has the ability to divert those calls to 911 or police, fire, or medical. And so the call center will have the ability to do that. But then also, within our mobile response team's contract, we want to make sure that our mobile response teams have the ability to provide immediate access within 1 hour. And so the call center will be responsible for identifying those families who are in crisis mode and who need someone to be actually face-to-face within an hour. And so the call center will divert those calls to the provider in the county where the call came in from. And that provider, in order for that provider to be able to access that child and family. We're looking at this as an opportunity for a warm handoff, and then also electronic information that will be ready real time. And so the call center will be able to enter demographics and information on the family and actually warm handoff those calls to the providers. And so the thing that we also wanted to make sure is that in the instance that a call is dropped, then that information is available so that provider can pick it up through the electronic database and be able to contact those families. And so again, one way to look at how we triage those are those immediate needs where families need access face-to-face within 1 hour, and then also we have a deferred mobile response system where we actually need our providers to make sure that our families have access face-to-face within 24 hours. And oftentimes we see that is when families are really not able to meet because they're at work. They may have called during the daytime hours and they won't be home until the evening, or for whatever reason they need a delayed face-to-face. Okay? And then also you'll see where the warm line will allow for verbal consent for families to be able to be contacted by the mobile response providers. Okay? Our mobile response teams, we have a pretty much a criteria for them. In their contracts, it talks about the face-to-face response. It talks about the ability to be able to provide de-escalation skills. We provide a lot of the evidence-based trainings that we use for our providers at no charge. And so through our Systems of Care expansion grant, we're able to provide training to providers across the state to have things such as MI, such as crisis management training in order to de-escalate crisis. We also train them in functional assessments and crisis planning for families to be able to identify those triggers and coping skills to help families to get back to a place of stability. And so as you will see in the slide, there's a couple of things that we require, such as a face-to-face follow-up services. We require our providers to have access to clinical treatment as well as assessment from an LBHP. And LBHP in the state of Oklahoma is a licensed behavioral health provider. And then also to be able to provide stabilization services in coordination within 8 weeks. Our mobile response teams are staffed with care coordinators and family support providers that are trained and certified to utilize not only the wraparound model, but is also trained and certified to provide crisis de-escalation. We also have recovery support specialists who are also a part of some of those teams, behavioral health aid, and all of those teams have access to a licensed behavioral health provider, whether it be through the utilization of technology or whether it's actually in person. When in fact a young person is not able to stabilize and that crisis to be diverted, we want those families to have immediate access to an LBHP. And so a lot of our LBHPs will be there in person to do a face-to-face, or we actually use technology as a way to bring them in face-to-face. Immediately following the stabilization, we also, through our provider's contract, require that the families have access to ongoing treatment services as well. And as you'll see on this slide, in the west region of our state, we have what we call community-based authorization services. So right now we're on a trial run with some of our providers where when in fact a kid is in crisis, our mobile response teams will be able to aid in those crises. The LBHP will also be a part of those teams in order to identify when a kid is assessed that needs a higher level of care. When those kids need a higher level of care, we have immediate access to our Oklahoma Health Care Authority LBHPs, which is our Medicaid provider, in order to do two things: to do the identification of a bed space that's within close proximity to where the child is located. So, we try to look for the facility that's closest, the psychiatric facility that's closest, as well as to be able to do a pre-authorization. And so what happens is that local LBHP will go through a criteria really looking at medical necessity for inpatient care and go through that with the LBHP at the Healthcare Authority. Between the two LBHP, there will be a determination made that this kid is in need of inpatient care, and a pre-op will be made. Once that pre-op is made, then the actual mobile team is really working with the family in order to get that young person transported to inpatient care. When they're transported with the pre-op, it allows that young person to immediately go in inpatient. This right here has really been a good, a good way for a lot of our community partners, such as our Office of Juvenile Affairs, as well as our Child Welfare DHS partners, because what it does is it prevents them from driving to different psychiatric inpatient facilities looking for bed space, and then also being turned away because the kid doesn't meet criteria. And so that community-based authorization is really authorized at the community level with the local providers in order to help young people who are in need of inpatient care to get inpatient care. Once that inpatient authorization is authorized and the young person goes in, those providers also are the authorizers of the extensions or the continued care. And what that looks like is because most of those providers may be working with those families, or at that time begins to start working with those families. It is believed that those providers know those families best because, again, a lot of these kids are in treatment with them, and they will work with the kid and the family while the child is inpatient in order to look for a plan for stabilization and a return back to the community. And so when that inpatient providers ask for that extended off, those providers determine if that extension is going to be given or if that extension may not need to be a 5-day but a 2-day stay. Okay. Ultimately, we continue to work with the Healthcare Authority. We have docs and psychiatrists on board that actually looks to review to make sure that the appropriate decision is made. Okay. Once our kids are in the community, and we're able to stabilize them and prevent them from going to any other higher level of care, going inpatient. We have an 8-week stabilization service criteria that we put in place. And for each of our families, that may look a little different. And so what we do is allow our providers to work with those families, putting services in place, primarily services that can go into the home and work with the kids in order to stabilize them. Oftentimes we put services in place like BHA services where you can work with the kids in the home or working with the kids in the school, the family support services in order for families to have a one-on-one peer support in order to kind of help navigate any situation that they come across or to provide some additional education and support, maybe connecting them to our statewide family organization that provides support, and then, of course, our care coordination services and case management services. All of our kids will also have access to therapists and any psychiatry needs for medication consults, as well as us looking at how to put a plan in place that really focused on health and wellness. Oklahoma is an integrated care state. We are a health home state. We have health home services for our kids statewide. The providers that are our mobile response contractors are also our health home providers as well. As a part of the 8-week stabilization services, we look at our behavioral health services in 2 ways. One, as preventive as well as stabilization. What we ultimately want to do is, if there's a possibility to prevent those kids from moving out of their home or out of their community, we want to make sure that we put BHAs in place in any community area that's needed. So that could be the school, that can be in after-school programs, that can be at home, one-on-one. It just really depends on what the need is. But then also we utilize our BHAs for that aftercare stabilization. And so what that will look like is when kids come out of the inpatient facility, we want to make sure that we have staff and BHAs in place to help them to go through that, what most people call it the honeymoon period, but that process of stabilizing and helping the family to put structure and things in place to maintain that stability. And so again, looking at it as a prevention, a day-to-day interaction to helping children to stay out of higher levels of care, but then also to look at it as a way of stabilizing kids that are coming out of inpatient care. And so, and again, a lot of our families will have access to needed services such as wraparound as a way to support them and maintain them in their homes and in their communities. And so just as I'm wrapping up, and again, thank you for allowing me to talk about Oklahoma's model today, I have a couple of questions. I just really want to know your thoughts, any comments or any questions about Oklahoma and how we look at our children's mobile stabilization system.
Y'all can, if those of y'all would like to ask some questions, you can use the chat box, or you can unmute your phone and go ahead and just ask Shamika any questions you may have about Oklahoma, or share any thoughts about your own mobile response and stabilization systems challenges that you've had in implementing those, or similarities to the approach that Oklahoma has taken. So there's one question. Michelle Hill is wondering about areas that take more than 1 hour to get to.
So Michelle, in most of our counties, there's less than an hour from either direction. And we definitely know there are times when our response providers can't get there immediately. So what we do is we have our families to meet us at the local hospital so that they don't have to, again, wait when in fact it is an emergency. But most of our providers are in areas where it's an hour or less to get across the county. And so we have 77 counties, and we have providers in all 77 counties.
And Caroline is asking, she's curious about the funding structure. Are you using system of care funds for infrastructure, and/or is it on your Medicaid waiver?
So currently right now we are using, well, we have a combination of funding. We do have some state funding that we use that has been allocated by our state legislators for our systems of care. But we have the SOC expansion grant that we're using, but then also all of the services that are provided are billable to Medicaid. And so we use our grant as a way of supporting the infrastructure for those providers. Yes.
Okay. But all the actual services are going to be Medicaid billable?
Yes, all of the services are Medicaid billable.
Okay.
The only thing that's not is to, all of our providers have staff that are on call, so that on call is not billable, and then some of the travel is billed through their state contract. So Medicaid, with Medicaid cover, we have a state contract that will cover those services, state funded.
And let's let this be the last question. Any thoughts on states that may not have additional funding for non-Medicaid kids?
Well, I think that, again, Oklahoma has been fortunate that our state, our legislator has been able to allocate funding to our systems of care for that. In our state, we do have Medicaid waivers that, we use for different things, but that may be some of the options. Looking at Medicaid waivers, looking at some blended funding prior to our SOC2 grant. Had a little bit of funds that came from our state child welfare agency in order to stabilize those families that were in foster care. Because, again, this is any child and family, and so really looking at other agencies and what funding they may be able to allocate to support the structure that's going to provide for their kids as well. And then also just really advocating to your the diversion of funding, such as, really looking at ways that once you can show the benefit, maybe diverting state funding from higher levels of care to lower acuity levels, such as mobile response and stabilization.
Yeah, and Shamika makes a good point that even if the services are all Medicaid billable, not every child is Medicaid eligible necessarily. Right. And so you really do have to have a mix of different funding sources to do a comprehensive mobile response across the state that's accessible to everyone. And using dollars from the Child Welfare Agency or Juvenile Justice Agency and pooling those dollars, I think, is a way that some states have been able to do that successfully. Thank you, Shamika, so much for sharing your expertise with us. And if we have extra time at the end after all the presentations, we'll open it back up to questions to everyone. So we might get back to this later. So we're going to move now to Southern Illinois, and Matt Buckman is going to talk to us about how he's led the development of evidence-based practices in rural settings. Matt?
Thank you very much, Shannon. Yes, my name is Matt Buckman, and I serve as the clinical director for a county-based regional system of care project. This is now we're in our second funded period of time with the Expansion Sustainability Grant. The name of our project is called Project Connect 2.0. The original was 1.0. Focuses on 4 rural communities, Saline, Gallatin, White, and Hamilton counties in southeastern Illinois. What I want to talk about today is about some of the efforts that we've had as a state and as a local community on trying to create and expand the capacity for evidence-based practice implementation in rural settings, and also how to sustain those implementations, that implementation. And so we've had some successes, some challenges. This has been some work that we've been working on for many years now. In my work, where I'm at, we're in a highly rural area, well beyond what would be considered a, maybe meeting the guidelines for rural. But we also are on the border of both Indiana and Kentucky and not far from Missouri. And so in that, it creates some complexity as far as our location in our state. So looking at our needs, there were a few things that we had identified. So we've identified that for our rural communities, there was very limited access to evidence-based practices. And when I'm talking about evidence-based practices, you know, there's a lot of focus on this. It's a phrase that's used often, but really what I'm talking about is something that has good evidence and can create good outcomes for our kids. If we look at some of the earlier studies of systems of care, unfortunately, having some of the principles in place and not all of the principles in place that currently consist of what system of care is, we're not getting great outcomes, client outcomes. We might be saving money, which is a good methodology or a good reason for this. However, we also want to get good outcomes for our kids and our families. And so evidence-based practices really is what links all of that to the infrastructure changes into actual benefit to our youth and our families. So, you know, we really want to be able to improve the quality and to be able to create meaningful change in our communities. And so we had limited access to those who could actually provide that service. For the most part, their training consisted of what was covered in their master's program. We also had difficulties with retaining those individuals who we did get training for. And so those individuals, even within our own organization, would move up to become supervisors or advance themselves. And in ways, we actually help them move out of the role of providing direct service and impacting the lives of our kids and our families, which was an inadvertent consequence. Many of them would also be more competitive in the marketplace, so they would go to higher paying systems outside of our mental health agencies, and those individuals might end up in the prison system. Even our child welfare system actually is a higher paying system, and so they might move into those, and education systems for certain jobs they would move into as well. Some of which I actually celebrate because they end up in places like we've helped some of our providers open up practices that are integrated in primary care settings. And now through those relationships, they are, you know, continuing to provide services to children and families and bringing system of care principles and practices as they move into other places. And then pay is oftentimes a challenge for our setting and most community mental health agencies or mental health agencies that primarily serve children who have Medicaid. Pay has been a challenge, and so individuals are oftentimes leaving for more pay. Also, one of the other needs that we had is that we have a large workforce of bachelor's level providers. And so several years ago, we developed a partnership with a private organization, private university that actually would come on site and provide training for a master's program in counseling. For those who didn't have the means, had a lot of different factors that really got in the way of their participation in classes and advancing themselves. And so when we first started working on this, I was providing a lot of training and we would do this, but what ended up happening was some of the foundational skills and foundational knowledge that a person gets in an advanced program like a master's program was lacking. And so instead of trying to provide a master's program, then do it, we are trying to link them in with different master's programs throughout the state, specifically our region. And then when grant funds were here, we were able to provide a lot of trainings and supervision and consultation and the fidelity that's related to evidence-based practices. But unfortunately, some of these systems and some of the best evidence-based practices out there are very expensive to develop and then also very expensive to implement and very expensive to maintain. And so for community mental health agencies and for some states like the state of Illinois, we don't currently have a budget. We have some financial struggles, and so the money is oftentimes a resource that has ups and downs. And so when the money's here, it's easy. It's preparing for when the money's not here. And so that's where the capacity building is really important on how to sustain these efforts. And then lastly, we lacked any local or regional trainers in evidence-based practices. There are training programs out there. Many times SAMHSA is funding different programs. However, in our particular region, we didn't have any trainers available to us without having to hire them to travel to our community. So that brings me to a polling question, which is, what are the biggest barriers you find to implementing evidence-based practices in rural settings? Yeah, costs, availability. So it looks like similar challenges, and cost being the #1 challenge. #2 looks like workforce meeting training criteria. So thank you very much for that. And thank you for, that poll really helps me consider kind of what can be helpful here. And so it sounds like you're running into some of the same issues. And unfortunately, when we are funded SAMHSA projects, some organizations will reach out to us and maybe propose higher cost for evidence-based practice training programs, which there's some research that supports going with the actual developer or certain individuals, and then sometimes the research is lacking there, that there's really not research to show that you have to be trained from this particular person, and that there are some trainers out there that are recognized by the organization but maybe are more affordable in implementing that. So a couple of things that we've targeted here. 2 specific populations are subpopulations that we're interested in our grant and our projects right now are developing infrastructure and improving the quality of practices for those individuals who are at risk or involved in the juvenile justice system. And then the other is targeting early childhood mental health, those young children, early identification, screening, and then providing services at a younger age that are family-based that can impact the children's lives. For the target of juvenile justice, we actually did partner, and one of the things that was talked about in the question and answer session was, kind of pooling money together, and that is very much an important practice that we've gotten to do here. We have what's termed Illinois Redeploy, and so with Redeploy funds and with juvenile justice funders, we've combined our efforts together in a way that we're able to provide pretty costly training, but in an affordable fashion. And so functional family therapy is the intervention that we have targeted as this is the intervention that we're going to train our providers in and are currently participating in that training program with Sexton out of Indiana. The other is targeting early childhood mental health. So there's a couple of treatments that we've identified here, and we have the governance boards and infrastructure that all of our system partners and families and youth, they can all provide the input that help us choose some of these practices. So the 2 practices that were identified are parent-child interaction therapy and child-parent psychotherapy out of that group, and then the other is early childhood mental health consultation. With early childhood mental health consultation, that was one that it has, good research overall, and it's a good philosophy, but depending on which program, some programs have research for it and some are just full of really research principles. So for parent-child interaction therapy and child-parent psychotherapy, there are restrictions on who can provide those services, and so that is a barrier for us, whereas early childhood mental health consultation allows us to be able to provide services with providers that may not have a master's degree, and even with parent-child interaction therapy specifically, that one you have to have a license as well. So that's more challenging for our workforce. And then traumatic stress. And so using trauma-focused CBT and cognitive behavioral intervention for trauma in the schools. TFCBT is kind of similar, although there are some online training programs. There's the TFCBT Web, and CBITS has its own online training program. The TFCBT Web doesn't necessarily allow someone to then start providing that service, but it is a great tool and a great online resource. CBITS, though, you can go online and get that training, and the manual is available for free as well, and so that's something we've been trying to grow throughout our system. But TFCBT, to be nationally certified, you also have to have a master's degree or higher and be licensed. And then lastly, we kind of general mental health needs some larger package type of programs that reach more people. Managing adaptive practices through PracticeWise. That's been a large one that we've been working with, that we've identified as a great evidence-based practice system to help infuse evidence-based practice principles and strategies with their practice guides and process guides. And then Incredible Years, a parenting program, and Nurturing Parenting program. Sustainability strategies. So again, we can do a whole lot when we have money. It's when we don't have money that I'm really concerned about, and that's what I'm preparing for while I have money. So what I want to do is train and retain the current workforce. So providing that training. We've started to go a little bit more upstream as well. There's a couple projects, the Trauma Fellowship out at Southern Illinois University, and some other programs, an integrated behavioral health program at 2 other universities that we oftentimes have interns from. We want the interns, train them even earlier than when they join our workforce, and then also training those individuals while they're still in their master's program. So we're training them on system of care and on certain evidence-based practices to help them to be able to be more prepared versus us, someone coming out with primarily knowledge and understanding of children and families, but not necessarily good practice experience or knowledge about what to do and how to do it. And then the other strategy for us is to provide ongoing supervision and support fidelity internally. The fidelity monitoring with several evidence-based practices out there in organizations is very expensive for the ongoing. So beyond the initial cost, the ongoing cost makes it less feasible to be able to maintain some practices. Some in the neighborhood of $50,000 for one site every year. And so those things just aren't affordable for an organization like ours, nor for individuals who are providing services in mental health settings throughout the state of Illinois. And then another strategy is we want to promote and create trainers locally within our own agency or within our partnering agencies within the system of care. So we might be able to provide them with sending them to trainings, helping them apply, help connect people together, network together, so that we can get a local workforce that is certified and licensed by evidence-based practice systems to train themselves. The other thing that we've done is partnering with the state lead agency. So we have a bidirectional relationship with the state system of care initiatives and grants. And so what we do is oftentimes we're the first pilot for things. If they have resources, they can send it down to us. We can try some things that maybe isn't prepared for or ready at the state level, or maybe it's not completely bought in, but if they want to have a case example, we can do it, or we'll do it, and then we bring it to them to let them see like outcomes that we were able to get by implementing something new. And then the local capacity is what we talked about earlier. So in developing local capacities, one of the things is master and regional trainers are very far and few in between, in that in Southern Illinois and many rural settings, unless there's a larger university that's in that setting, many of these trainers are not available, and they have to travel long distances, and this is a big part of their profession. However, those trainers can be quite expensive to be able to retain. And so we're supporting and applying for acceptance into the training programs for several different training programs. And then potential applicants not having the experience that's needed, so we start doing long-term planning. So right now, I started off with a clinician that was interested in trauma-focused treatments, and now we went ahead and got her trained several years back in EMDR, and now she is getting the further training to become a level 1 trainer in EMDR. So we're these long-term relationships and trying to develop individuals who are interested in this and have the skill set to do so, helping them reach their goals, and hoping and trying to ensure that they stay within the system of care. Doesn't necessarily have to be at the agency that I'm located at, but in the system of care to provide those supports. Also, in many of the systems, many of the evidence-based practice systems, there are different levels of trainers. And so level 1 or agency trainer or supervisor, those terms are used a lot of times. And from a system of care perspective, it doesn't quite match well, whereas right now our funding comes through, and the fiscal agent is the county government and Egyptian Public and Mental Health Department. However, from a system of care perspective, we're looking at multiple agencies that are all within the same system of care, and so there's been some advocacy that's needed there, whereas normally they just recognize you can only train within your own agency. A couple of different things that we've looked at: managing adaptive practices. The state of Illinois has done a great initiative to be able to train a group of people as providers, a smaller group as supervisors, and then 4 of us throughout the state that will be training professionals. So we're going to be able to, and we have to sign something that says we're going to stay in the state, we're going to continue, and we're willing to provide at least 30 days worth of training. So developing that local capacity to go around and provide training throughout our state. Functional family therapy is one that they've been very open to allowing us to use a system of care framework and even a juvenile justice regional perspective. So beyond just our system of care, our juvenile justice redeploy and counsel is actually funding the majority of our functional family therapy training program, and then we're providing the infrastructure, and we're going to have the ongoing supervisor that in 2 years, then there won't be any additional costs that are related to functional family therapy outside of booster training and the online outcome management system that Leonard Buckman had actually developed, and it's called the Care 4. But these 2 things then are pretty minimal in that it's going to cost us about $8,000 a year on an ongoing basis versus some that can cost upwards of $50,000. The other thing that I like about it too is that as long as they are qualified to be able to provide services within your system, whatever the laws and regs are, then functional family therapy and managing adaptive practices do not define who the clinicians have to be. And so you're able to train individuals who may not have master's degrees, and I've seen it both ways, where sometimes someone comes in with a master's degree and it seems like they have very little knowledge or experience. And I've also seen it where sometimes someone has a bachelor's degree or even a peer support provider that has wisdom and knowledge and knows more about evidence-based practices than maybe I do. And then the other one is parent-child interaction therapy. This is one of those systems that typically it's an agency level. However, what they've worked with me on is that we're able to train from a system of care perspective. So in rural systems of care, the entity becomes the system of care versus an agency. So instead of having to become one of the 20 master's trainers in the entire world, we're able to do that as a level 1 trainer, which is more readily available. Level 2 is more regional, and then master trainers can train anywhere. Lastly, trauma-focused CBT, also working with the developers of trauma-focused TFCBT and allowing for training and supervision, consultation that's needed for fidelity and for certification, that can all be done now from a system of care framework versus just looking at the agency. And so kind of explaining what system of care is, multiple agencies are involved, that was something that they were interested in doing as well. So some possible future directions are, supporting more evidence-based practices. Those are just the ones we're interested in, but how do we get that rural systems and rural systems of care are different than more urban areas, and how can we provide these services where in some of my system partner agencies, there's really only one or two providers. And so in that, if they became a trainer, the only person they could train is one other person if they were at the level 1. So recognizing that systems of care, especially rural systems of care, function differently. The state capacity development, we've got at least two projects. There's some others as well, but two projects specifically, one on the neurosequential model of therapeutics and education with Dr. Bruce Perry out of the Child Trauma Academy, that is through our state Board of Education, and then the other through our lead Medicaid agency, which is managing adaptive practices through PracticeWise. And then lastly, our next collaborative projects, looking for where do we agree from juvenile justice, child welfare. All of our organizations are putting money in different things. What I find is that training initiatives happen, and the maintenance of that doesn't end up happening. And so there's large amounts of money and resources put into something, and then it kind of fades away, and then there's a new, more popular evidence-based practice that might be out there, that then we jump ship from one to another, and then we're redeveloping all of this infrastructure again. Some of the greatest evidence-based practices are not the brand new ones. They're the ones that have been tested, and we still see it. They may not be as exciting and sound as interesting, but if they're the ones that work, we really want to make sure that we're implementing those practices. And then lastly, to include more of this in higher education programs. So I'll use managing adaptive practices as an example. To be able to become instructor certified is actually very easy. That you can provide training to those individuals while they're still in their advanced training program. So definitely something that we want to look forward to in the future. That being said, thank you for allowing me the opportunity to talk a little bit about our system of care and our efforts in developing and increasing the capacity within our region and our state. I would love to hear any thoughts or comments, questions, anything that you might have. Feel free to enter that in or to unmute your phone.
Thank you so much, Matt. So let's take a few questions. You can either, again, unmute your phone and ask directly, or type them in the chat box. Why don't you share, Matt, a little more about just how you manage that advocacy process with those various EVP owners, originators, about getting them to understand better the needs of the rural area, and what were some sort of like key arguments that you made, or what did you feel like were, why do you think you were successful in getting that done?
That's a good question. I would say that, some of the strategies that I've utilized have been, I actually go to wherever they're providing the training. And so if they're doing a presentation, so like I went to Miami, not too hard on me to go to Miami, but I went to Miami for an evidence-based practice conference to talk with Tony Manarino, who is one of the co-developers of TFTBT. And so, having that face-to-face conversation that they know who you are, and I had a colleague of mine actually connect us even before that over email. So the relationship matters, in all things that we do. We know that for practices, therapeutic alliance is the #1 factor. All of this matters, and so going out and meeting them, talking about what system of care is. I think system of care is kind of like evidence-based practices. I think it's thrown around a lot, but is it what we intended it to be? And so some people, some of these organizations, they don't understand systems of care, or people have misused the term system of care. And so educating them on what that is and the reality of rural practices, and some of your areas are even frontier areas. And so the reality of that being that we don't have an organization with 50 practitioners in one organization. Our practitioners are spread throughout, and so most of them, they actually they've even allowed these types of things to happen before. The difficulty is for us in rural systems of care is that we don't do things like these learning communities where we're not always sharing some of this information. And honestly, if somebody else has successes, I would love to hear them, and email me those, or you can always share it on here. If it works for you, I'd like to reach out to the same organization, because once you pave the way, that kind of works out. So most of them, if they understand system of care and they understand how rural some of our communities are, and they trust you as a person, those are probably the three best strategies for advocating.
That's great. And so, I would encourage those on the webinar to actually do what Matt just suggested, to maybe follow in his footsteps with some of those practices that we're willing to work with him. Caroline has entered a question. She says, do you run into sensitivities around clinical consultation across agencies within the system of care?
Sensitivities. Carolyn, maybe you can clarify sensitivities for me, and I'll start answering the question a little bit while you're doing that. But I think for us, there's strong differences in language and things like that around systems of care, right? If someone has, from child welfare, they're working with different regulations, juvenile justice, they have different terms like petitions, et cetera. And I'll go back to the relationship. If I have the relationship and enough understanding, I can do the translation piece between what they're talking about is basically the same thing as what I'm talking about, or others are talking about, and that it allows us to kind of get on the same page and work together. Some folks with consultation to be provided, some folks are very strict about who's providing it. And so credentials of your consultants and your trainers oftentimes matter. And I'm a clinical psychologist, and I will talk about my group the most, I guess, because I have more experience with that. Some clinical psychologists do not want to be trained by anybody else but a clinical psychologist, and so they kind of have these biases. And so I notice some sensitivity around that and kind of some misperceptions about one practice or one discipline being superior to another discipline.
Interesting. Well, I see Miriam is typing a question. Let's let her get her question in, and that'll be our last one. Okay, Miriam's from the Puerto Rican System of Care Initiative. And did you have a question, Miriam?
I want to be a part of the Puerto Rican. I want to do that.
All right, well, let's move on to the next presentation, and we can take, again, more questions at the end. So now we're going to thank you, Matt, for that presentation. Really interesting.
Thank you.
So now we're moving on to New Mexico to hear about strategies using telebehavioral health. And we're going to be hearing from Bryce Pittenger, Alicia Iverson, and Caroline Bonham. So
hi, everybody. Good afternoon. This is Bryce Pittenger. I'm the Behavioral Health Services Director of our Children, Youth, and Families Department in New Mexico. I'm the authorized representative on our Communities of Care grants. Alicia Iverson is our project director on the Communities of Care grants. And I have the pleasure of introducing Caroline Bonham, who is the New Mexico Behavioral Health Collaborative psychiatrist. She actually wears a lot of hats and does a lot of things, so that's a very limited description of who she is and what she does. So I just wanted to set a tiny bit of context with regards to New Mexico. We've got one person every 12 square miles. We like our space here in New Mexico. We've got about over 2 million in the state, but concentrated in our metro areas of Albuquerque, Santa Fe, and Las Cruces down by the border. So we've got a lot of rural and frontier areas, and as you all know, and Carly will start to talk about Project ECHO and some of the initiatives that have come out of New Mexico with regards to reaching for consultation and even direct services, some of the frontier areas that we have. My hat's off to our sister states there for what they're doing. Like Oklahoma, we've used our communities of care grant dollars to build infrastructure, credentialing, coaching, training for high fidelity wraparound. And we're trying really hard to figure out a way to create sustainability in our state for that. We've got some social determinants of health here that I'm sure other people do too that work in rural and frontier areas, but we're 50th in the nation with regards to poverty, 8th with regards to teenage pregnancies, and the list goes on. And so at this point, 68% of children in New Mexico are on Medicaid. It could be that others are eligible, and we're working hard to do that. There wasn't much of an expansion of children when we did the expansion of Medicaid. It largely applied to adults, but we do have a lot of children that are in our state and do not have some sort of legal documentation status. And so my agency maintains the funds for services for those children, our children that don't have access to Medicaid because of their documentation status. So I'm gonna turn it over to Carly, but just one more little thing. Every state is different. The Children, Youth, and Families Department has 3 or 4 major divisions. So we have child welfare, which is our protective services. We have juvenile justice, and we have early childhood. And we also have our behavioral health services division. We have a bifurcated system here in New Mexico, so we are the Children's Authority over behavioral health, as well as, so we license and certify programs, as well as fund infant mental health through our division in hopes of eventually getting that on our waiver renewal in the 2.0 next year. So we've got a lot of initiatives. Our top 3 are wraparound infant mental health and bringing up family peer support, as well as certifying and licensing all the shelter cares for children around the state, and working with a target population within child welfare and juvenile justice to identify least restrictive and trauma-informed strategies to help those children, especially that are deep into multiple systems. So I'm going to turn it over to Carly, and thank you so much for your participation. And Carly, take it away.
Thank you, Bryce. So today we're going to give a little history of the telemedicine in New Mexico and talk about some of our current use with populations with a focus on children, talk about some lessons learned, and some of our ideas for future use. So as Bryce was saying, we've always had a challenge of serving people in rural areas. And so we've had clinical telehealth programs dating back to the 1990s. Project ECHO, which is getting a national reputation, started in 2003, and that's primarily a case consultation model with health mentoring via telehealth. So it's usually provider to provider, and that's been very successful at looking at a range of conditions. It has been primarily adult focused. The New Mexico Telehealth Act was passed into law in 2004 and updated in 2014, which means that we have regulations in our state clarifying the use of telehealth for clinical care and also helping provide a basis for reimbursement. So New Mexico Medicaid also passed telemedicine regulations in 2007. And then we had parity telemedicine laws passed in 2013, documenting that if there's good evidence that a clinical service can be delivered equally by telehealth as in person, then it should be covered. And that our managed care plan with Medicaid really incentivizes telehealth, and so each of the managed care contractors are expected to expand their telehealth office visits by 15% per year, and they had a 45% increase in utilization of telehealth in 2015. So what is telehealth? Telehealth actually, and we'll talk about this, covers a wide variety of strategies. It's the use of electronic information and telecommunication technologies to support long-distance clinical health care, patient and professional health-related education, public health, and health administration. So as a polling question, how many of you are aware of telehealth initiatives in your states? And then including the following modalities. Okay, so a lot of people are doing the education via telehealth. Some are doing clinical supervision or clinical consultation. About 40% are aware of some sort of direct clinical services, and I'm curious about the different model of telehealth, too, that people are mentioning. Okay. So I was going to go through these different models. The education is very helpful in behavioral health. This is what we're doing now, is facilitating education and learning collaboratives on behavioral health topics using technology. Consultation is usually, this is the ECHO model, where multiple providers can take part in a video case consultation. And it can be shared knowledge, or there can be facilitated by a provider or a supervisor to ask specific clinical questions. The supervision, and we'll talk about that in detail, is the supervision to trainees and practitioners via telehealth. And then the direct service, where a patient or a client is on one end and then can receive clinical assessment, therapy, or education or medication management from a clinician on the other end. So for our telehealth and education initiatives, we have weekly telehealth sessions with continuing education credits that are freely available to clinicians. But also we encourage participation from staff from schools, social services, and other agencies working with youth. So we've done about 250 presentations since 2010, and we often will repeat presentations that we will get frequent requests. So we often get a lot of requests for telehealth education sessions on suicide assessment, on class management strategies, psychiatric medications in youth, and how to best implement trauma-informed care. The teleconsultation is this model of using video conferencing technology for generalist providers to seek specialty consultation. So it could be primary care providers who want to consult with a child psychiatrist, or it could be therapists who again want to consult with somebody who has specific expertise in a particular practice. Or again, we use this a lot to liaise with school staff or parents who again want to maybe participate in an IEP over telehealth, or kind of group around to make sure that we can provide the best care for a child and a family. So if it's around a clinical question, the responsibility of documentation, prescribing, and clinical decision usually resides with the on-site clinician. So for example, if there's a primary care who's consulting with a psychiatrist, the primary care who's working with the client would be documenting and would be issuing that prescription if it's around a medication question. The consultant is not necessarily credentialed or privileged across the systems because they're not directly providing care to the individual. And if private health information is being shared, you must ensure that a confidentiality is protected. And so whatever platform you're using needs to be HIPAA compliant. And so there's a number of different versions of software now for telehealth that are HIPAA compliant. So Project ECHO uses teleconsultation to promote knowledge sharing through a hub and spoke model. And as I mentioned, they do this for a number of different conditions: hepatitis C, addictions, psychiatry, but also rheumatology, neurology, chronic pain, but have generally had an adult focus. We've also, for the last couple of years, started an initiative around telesupervision to expand workforce capacity. So in our state, when we looked at the number of social workers around the state, about 50% had an independent license, and then 50% had still not completed their full set of supervision hours to achieve full independent licensure. And there was a huge disparity because most of the non-independently licensed social workers were in rural areas. And when we started to look at the map, we realized it's because there may not even be an independently licensed social worker in their county. And so it made sense that they weren't able to get that access to supervision to move towards full independent licensure. So this kind of model will need to be set up differently for each state depending on state licensing regulations. But we've made sure that this was part of New Mexico law and New Mexico credentialing, that for social workers, telehealth supervision was going to count towards their supervision hours towards independent licensure. So we've now started a model where we provide telehealth supervision to groups of pre-licensure or non-independently licensed social workers in rural communities, and they get 20 hours of group supervision where they work sort of in a collaborative way. That counts towards their supervision towards independent licensure. And then once they move past those 20 hours, they get one-on-one telehealth supervision. And really the focus of this initiative has been around children's providers too, because we want to really deepen our workforce around children's behavioral health. So the clinical supervisors who at the hub site who are providing those supervision sessions are child trained and have expertise in children's behavioral health, which has been a real value as the clinicians working in these rural areas really see anyone who comes in the door, and it's really nice for them to have that opportunity to kind of think through how to best serve the children that they're seeing. If for this model, you're often talking about individual cases, so if private health information is being shared, it's also important to use a secure platform that's HIPAA compliant. And as I mentioned, we're using this in New Mexico to hopefully, over the course of time, increase the number of independently licensed social workers in rural communities. We also do a number of direct services via telehealth. So this is using telehealth, an interactive audio and video telecommunication system allowing real-time communication between the practitioner at the distant site and the beneficiary at the originating site. And using the CMS language, the originating site or the spoke site is where the patient is located, and the distant or hub site is where the licensed practitioner is located when we provide clinical services. So in our state law, you don't have to have a licensed practitioner at either end. And so very often, so I do a lot of telehealth clinical work. So I see people in rural communities, and there'll be an MA or kind of a patient service person on one end who'll escort the person into the room, and then I will do the session, I'll do the evaluation, and as a psychiatrist, I'll prescribe the medication. And then I make sure that we use the EHR on the originating site end so that I can document what happened and then make sure I'm collaborating and communicating with the local providers. And there's been a real big demand for child telepsychiatry because a lot of the rural counties don't have access to child specialty services. So some of the options are, that we've done two different options. One is the direct service where the child will come and see a child psychiatrist directly through telehealth. Other times, the child psychiatrist who sees the child will then work closely with the primary care provider in the rural site who will write for the prescriptions. Otherwise, we will sometimes, we can transmit the prescriptions directly through the electronic health record or through a fax. One thing that comes up a lot is children needing stimulants who may need stimulants for ADHD diagnoses. And so that's something to be very careful of if you're going to set up a program like this, because stimulants or other controlled substances are regulated by the Riot Hate Act. And so you want to make sure that whatever process that you use for transmitting those prescriptions is consistent with federal law. And so for each program, you want to make sure you clarify where the clinical documentation is housed and to ensure that it's transferred securely. So there's been a fair amount of research around telehealth, the efficacy of telehealth direct clinical care. And so patients tend to report equivalent satisfaction with telehealth compared to face-to-face interactions when the telehealth is conducted with experienced providers. And interestingly on that, and then there's also similar clinical outcomes. And so there's a similar reliability of the diagnoses, similar reliability of the AIMS score, that's the neurological score when people receive antipsychotics, and so that can be assessed similarly on telehealth. The Hamilton rating of depression scores and the Brecht Depression Inventory, again, they're similar, so similar outcome measures when we look at the treatment of depression by telehealth. And then also, really, when it comes to sometimes what's most important is how well is somebody functioning. And are they receiving good treatment that is allowing them to do better in all domains of their life? And so if you look at things like the clinical scale of global improvement or the Beck symptom inventory or the SF-36, which sort of measure function across domains, those are equivalent scores. There's also a number of studies looking at rapport developed over telehealth. And certainly as somebody who provides telehealth services, it's different than working with somebody in the room face-to-face. But in general, when patients are randomized to either receiving telehealth or face-to-face care, and they're asked to rate how much rapport they have with their therapist, patients tend to rate that their rapport is measured by task, bond, and goal, is similar, whether it's telehealth versus face-to-face. There was one of these studies actually that showed that the providers felt that the rapport was less, but the patients actually felt that the rapport was the same. So when we work with our telehealth providers, there's a few strategies that we do encourage them to use to enhance rapport because it is different. And we know that telehealth sessions sometimes take a little bit more time and more concentration than face-to-face sessions. So we encourage people to be lively with more expression, but not excessive, so about 110% of their normal affect. We encourage people to avoid wearing bright patterns or jewelry, and to be mindful of speech delays and limitations in visual definition. And so I'll often start the session and say, excuse me if I interrupt you by mistake. Sometimes there's a delay with the verbal communication. And some of our child providers are really actually quite amazing at developing rapport over telehealth, and they use puppets or toys, and they play hide and seek with the telehealth, and let the child use the zoom function or the controls on the camera to find the toys that the provider has hidden as they start the session. I also there's one child psychiatrist who always used to bring her puppy into sessions too, and that was always a really good way to develop rapport with the kids that she was seeing. The other thing that's sometimes not intuitive is that it's important to verbally clarify some of the nonverbal clues. So if somebody looks sad, I'll often have to say very explicitly, is there something that we're talking about that's making you sad? The other thing is that, as many of you are maybe familiar with using Skype, you can see your own self. So there's a picture-in-picture function. So for me, I've actually found it very helpful to kind of notice my own body language as I'm in the midst of a session and notice what I may look like. And I think that's helped improve some of my clinical care. If I'm doing a group session or a family session, it's not always clear who I'm looking at. And so I need to make sure I'm using their names rather than relying on eye contact. The other thing that is actually very key with what we've learned to really encourage our providers is that it's important to develop rapport with the patients and families. But really, there's a whole behind the scenes of the clinical staff and the telehealth coordinator and the other clinicians in the clinic that you may not bump into the hallways where you would in a regular clinic setting. And so reminding people to make active efforts to develop rapport with the other healthcare team members. It's also very important to anticipate possible clinical emergencies. And this does come up a lot as we're serving very vulnerable populations who are often high risk. So we make sure before starting a telehealth program that we prepare local protocols that contain information about the local regulations and local resources. And in New Mexico, we serve a lot of tribal communities. And so sometimes if we have social services concerns for children, child welfare concerns, or even actually if we feel like we need to get somebody into mandatory hospitalization. The legal mechanisms for doing that are different in tribal communities compared to our civil regulations, and so we want to make sure that our providers are aware of those. We also make sure that we clarify the roles and expectations of parties on both sides. So oftentimes we do telehealth from clinic to clinic. So we'll work with the clinic staff, the local clinic staff, about if something comes up and somebody is acutely unwell, who's going to sit with them, who's going to talk to the family, how do we get that person to a higher level of care if we need. And we also explicitly clarify our out-of-hours coverage and resources and make sure that we're maintaining updated telephone contacts between the providers and staff. I think as we look back at what the things that we've learned, the infrastructure for telehealth is actually that it still is an expensive investment. The equipment is getting cheaper and cheaper, and the technology is, but really the majority of costs are in personnel. So the administrative, making sure that we're in compliance with local and kind of regional regulations, doing the credentialing so that providers are credentialing across agencies. That we have legal reviews of the business associates agreements between each agency and across institutions, and to make sure that we're all in compliance with the federal laws of high tech and HIPAA. And so those are ongoing costs that haven't gone down as the equipment costs have gone down. And so there is some benefit of centralization of the telehealth infrastructure, because otherwise these costs end up getting borne by some of the small rural sites who may have relatively small caseloads. And we're also making an active effort to incorporate telehealth exposure during our training for our clinical providers so that they're more comfortable in their roles as clinicians. So some of the things as a state we're looking at next is we do have a crisis triage line that's been very helpful, and we've been able to stand up in the last few years, but looking at text capability for that. Exploring the use of apps to support behavioral health and wellness. We're also looking at maybe developing a possible centralized telehealth emergency psychiatric unit, because we're aware that in some of the rural areas that there's not quick access to psychiatry evaluations and getting people into higher level of care as needed. And then also maybe looking at collaborative care models via telehealth to expand access to integrated primary care behavioral health models. So I'm interested in questions, and I'm just reading Michelle's comment. In Michigan, you've been using telepsych services for children's medication, and you've seen some challenges in finding telepsych services to use. Any suggestions? And I think this gets to my what I was mentioning around the total cost is actually quite expensive. So what I've noticed is that there's a proliferation of private companies doing this, and they provide good care, but they can be quite expensive. And I think this is a challenge for some of the rural agencies to enter into an expensive contract. And so this is where, in my hope, there'd be more sort of state infrastructure, the state sort of a centralized model so that a state can provide these for some of the rural areas. We've realized there really is an economy of scale. And so it becomes very expensive for a small agency who's maybe serving kind of 6 or 7 families to contract for telepsychiatry. So Arizona's done this really nicely for a lot of their behavioral health systems. And I think also South Carolina has done this really nicely in terms of their emergency telepsychiatry system. So it's hard. There are really good quality providers, but I think the expense can be prohibitive.
Any other questions?
Any other questions? Any other questions for any of the presenters? In the chat box or on the phone? All right. Well, I want to thank each one of our presenters again. This is just so informative. And so we've got a note on here that says today's presentation slides are available for download into files. For download box below the chat box, click on the file name and then click the download file button. And we also, again, so you can go ahead and do that now if you want access to the slides. We also will send out a link to this recording to everyone that's on the listserv, and you're on the listserv if you registered. Michelle asked if there is any resource information that can be shared for agencies to pursue cost inquiries. That would be helpful. I'm not quite sure, yeah, for telepsychiatry. So New Mexico folks, would y'all have any resources like that you could share with the group? That's very helpful. Thank you, Caroline. All right. Well, I think we're just about out of time. Again, as I said, when we were opening up, the next webinar will be on Friday, August 4th, the same time, 2 o'clock Eastern. And you can there's the registration link right there if you want to go ahead and register. It will also be coming out in the TA telegram when we get a little closer, if you all get the telegram. So unless there are any other final questions, last chance for questions. All right. Well, thanks again to all of our presenters for sharing that fascinating information, and hopefully we'll all put it to good use. So y'all take care, and we will talk to you again soon. Bye.